Good morning, everybody. I am pleased to start this February meeting of the mayor and council. The chairman and I discussed a couple of things that would be helpful for this meeting, and we're happy to present some information on fire and EMS reforms that have been underway for the last 2 years. And our fire chief, Gregory Dean, will be here to make that presentation. We also understand that Metro's chairman, Jack Evans, and the Ward 2 council member will make an update regarding Metro, and that the council will make a presentation regarding Wilson Building portraits. So let me just say about fire and EMS. First of all, we're grateful to the council for working with us on some new initiatives that are helping to strengthen the department and make it more resilient. We know 2 years ago we were experiencing a huge struggle to keep up with call volume, and we continue to look for ways to both enhance our capacity, but also make sure our system is being used for true emergencies. We were running into the experience of running out of transport units that put our most critical patients at risk. We work closely with our labor unions and with the members of the council to invest $12 million in fire and EMS, which has been the largest single investment in the city's recent history. And now the department is stronger and more resilient than it has been in many, many years. Today we have more transport units. We've enhanced training opportunities, which was a critical promise we made here to have our personnel have more opportunities to train. And we are beginning to see our first response and transport unit times have become better and faster. And we have also vastly improved the condition of our fleet with more ambulances, fire engines, and ladder trucks. We've also been able to refurbish in the last 2 years 16 ambulances and put them back on the street. And these vehicles, coupled with our basic life support units, mean the department has 23 more ambulances in reserve. We've also been focused on hiring in the last 2 years, and we have hired 45 more firefighter paramedics, and we're planning to nearly double that number with 2 more classes of firefighter paramedics this year. We have also hired 48 firefighter EMTs and 36 cadets, the vast majority who are DC residents. So I'm going to ask Chairman if you want to make any remarks before I turn to Chief Dean for a progress report.
Thank you, Madam Mayor. I have no remarks. We trade who's hosting. This is your meeting, and so thank you, and let's proceed with the presentation.
Okay, Chief.
Thank you, and good morning, everybody. Before I get started, it's important to acknowledge my people who have been supporting us and helping us get to where we are, and that's Director Holmes from the Office of Unified Communications, Dr. Nesbitt from the Department of Health, and Dr. Holman, our interim medical director. A lot of the progress we've seen, starting with hiring, allows us to kind of set a baseline for where we are. As the mayor said, we've added 45 firefighter EMTs, 48 firefighter paramedics since 2015. In June of 2015, we had our first exam since 2008. And the results of that showed that we had 90% of the firefighter EMTs that we've hired off the registry came from the District of Columbia. We've had 2 classes of 35 cadets graduate since June 2015, and we have 1 class that will graduate in August of this year. We have a new firefighter EMT class starting in March, actually next week, and we have additional 2 firefighter paramedic classes that are 44 recruits that's scheduled to happen here in 2017. The chart is really kind of to show you where we were at this time last year and where we are today. The green tells you how many units we have available, and what it talks about is when you see the green, that means we have 11 or more units available. It's just this unit availability. The red shows you the challenges that we had, and this goes, that chart there goes through let's see, October, I believe, October of 2016. If you turn the page, you will, next slide, we will see that by January 21st, we are able to have unit availability over 90% of the time. And this is really having enough resources to be able to handle our increasing call volume.
Okay, thank you. Good morning. So this slide here shows OUC dispatch times, and of course, being that we are the onset of a 911 call, it's important to look at the changes that have been made and the progress that we have made. The orange represents the call to queue, so this basically is from the time the 911 call taker answers the phone until the call is dropped into queue for FEMS EMS units to be dispatched. And then the blue bar shows the queue to dispatch. So once the call has been dropped into queue, until a unit is actually dispatched for one of the OUC operators. I want to point out two outliers on this graph. The really long line up at the top for priority 3 calls in January of 2016 is Storm Jonas. So that prolonged, of course, we all, most of us went through that, so we know why that line is so long. And then further down on the bottom, this past January 2017, the priority 1 calls, the line sticks out. That's an outlier also that is just from inauguration and Women's March. So those numbers would be skewed because of the amount of work that occurred. What we want to point out to you is since January of 2016 up until this year, in this past quarter, we have saved from call to queue approximately 14 seconds, and then queue to dispatch is close to about 13 seconds. And what I like to explain is when I go to especially ANC meetings, when I come and I'm like, we've saved 20 seconds, you know, I get the, oh, okay. And when I go back and I do, and I say, let's count to 20. 1, 2, 3, and we go up to 20. And when you're in the middle of an emergency and you're calling 911, those 20 seconds are really critical. And so we're really proud at that time to shrink the overall call to dispatch time to 20 seconds. And actually it's closer to 25 seconds. And lastly, I would just like to add that the call to queue dispatch, we attribute that savings to, we started a quick send function in our CAD system. So prior to prior to March of 2016, an operator had to prompt our CAD system to send priority calls over to fire department. So if you're calling and you're not breathing, or someone in your family's not breathing, the call taker had to remember this is a priority call, send it over to FEMS now. The quick send dispatch automatically does it for us. The computer, after you ask certain questions, the computer say, hey, this person's not breathing, go ahead and dispatch it. The call taker continues to ask questions, it doesn't stop. So that has helped shave some time. And then the queue to dispatch, once the call goes into queue for dispatch, I would definitely attribute that shaving of 13, 14 seconds to the available resources that we have now in FEMS. Our dispatcher now have resources to dispatch. They're not pondering and looking and trying to find units to go. Those units are available, and so we're sending them out to be dispatched. Thank you.
Since the introduction of AMR, we have seen a big difference in our unit response times east of the river. And if you take a look at your map, you'll see the dark blues that are now east of the river. And what that really means is that we're able to keep our units in their first response district. You do see a heavy blue in the middle, and that is northwest where all the hospitals are. But overall, we're excited that we're able to improve our response times east of the river. And this is the next graphic shows you this in minutes. We've gone from our first response units going from 8 minutes and 7 seconds down to 6 minutes and 34 seconds in their response throughout the district, but especially you look at east of the river. Other things that have been going on in the department, one of the things that we had a lot of challenge with was with our apparatus. And so we have now a reserve fleet, 23 ambulances. In addition, for special events and First Amendment rights, we have to maintain 10 additional units to be ready for those type of events. We've been building up our reserve fleet, and since January 15th, we put a number of vehicles in service: 16 ambulances, 2 engine trucks, 7 ladder trucks, 10 command vehicles, a refurbished Fireboat 1, and a new Fireboat 2. We got to see the results of this buildup in ambulances this last summer during the hot months. We did not run out of ambulances because we had a reserve fleet. We're building that way now for our fire trucks and our fire engines. In fiscal year 17, we'll be procuring 18 new engine trucks, 3 refurbished engine trucks, 3 ladder trucks, and major repairs will be completed on 3 other ladder trucks, 1 rescue squad, 16 ambulances, and 5 command vehicles. Having that reserve fleet means this. Currently, if an apparatus goes out of service, we have to operate with 1 less apparatus in the fleet. A reserve fleet will allow us to be able to continue to serve those districts and not have them impacted by that loss of an ambulance. The next slide shows you what it looks like if we anticipate that we'll have our units available 75% of the time. So here's where we are with our ambulances now that we have a reserve fleet, that we're right there about 75% of the time we have ambulances that are in service and ready to go. Last year, in October of 16, we sat here and did the launch of the Hands on Heart program, and to train district residents. The council and the mayor's office were the first group that we trained. Our goal was to train 5,000 people. We doubled that with more than 10,000 people that were trained. The overall bystander CPR participation rate for cardiac arrest has increased by 22% here in the district. As of today, FEMS has trained more than 18,000 people, and so everybody's to be congratulated as we prepare our community to take care of each other. Under EMS reform, we're looking for more efficient use of our resources. Since June, the rate of BLS transports by ALS ambulances has dropped from 23% to 18%. And a lot of that credit goes to the medical director's office and to the Office of Unified Communications. And going through all our protocols, trying to find ways to make sure that we're sending ALS resources only on ALS calls. One of the things that we've been measuring is how long our units are staying at the hospital drop times. They've decreased by 3 minutes. In October of 2016, the average was 47 minutes and 27 seconds. We put out a directive saying that we wanted to reduce that to 30 minutes when we transport it. We're hoping that AMR will do that. As of, we've seen a reduction since October to 44 minutes and 15 seconds, something that we're going to continue to have to work with, but recognizing that some of these are out of our control. If the hospital's full, if they don't have beds, they tend to hold our units there. What this chart is trying to show you is the bottom shows you that fire calls have remained pretty consistent throughout the year. From 12 through 16, our fire calls remain pretty consistent. What we've seen a 24% increase in is our EMS calls, as we've gone from 137 and 12 all the way up to 170,000 plus in 2016. And again, that's more than 90 calls each day, more each day. And that is where you're seeing the impact. So if you remember back to the slide where you saw that we were 11 or more units available, and yet still we're being able to manage this increase in call volume at the same time, which is something that everybody's to be commended for. We are still working on improvements in the delivery of advanced life support. Our times have stayed, for that medic unit to get on scene, have stayed relatively the same, right about 6 minutes. We are looking at ways to improve that. And before I talk about this, I'd like to say that there are medic units in every ward. And so we're not moving any medic units around. What we're doing is in Ward 6, 5, and 8, we're taking ambulances and we're making them into medic units to help hopefully improve our ALS response times. We're working collaboratively with Local 36, trying a new staffing model where the members at that station will manage the details from the paramedic engine to the medic unit back and forth instead of having details come in and out. We'll see how this pilot works. If it does work, we'll apply it to the whole organization. We did an earlier pilot with Local 3721 for about 6 months, where we moved them to a 24-hour shift to create teamwork. That worked, and we moved them onto a 24-hour shift, which has helped unit continuity. And then, again, talking about paramedic response times, as you can see, there's only been an 8-second improvement in getting paramedics there. Again, I think what's important to talk about is that paramedics are what we call the continuum of care. And the baseline is that we really need our EMTs to get there and to set up and do what needs to be done. And that is the way it's looked at across the nation, is that your EMTs are your critical forces. And we continue to improve in that, and we're continuing to improve in their training. And Dr. Holman, you want to?
Sure. Thank you. Good morning. The next slide talks about EMS reform leading to increased training. And since the rollout of AMR on March 28th last year, for the rest of 2006, we did see a 33% increase in EMS training hours since then. That really does demonstrate what we've been doing with the relief afforded by the AMR rollout. We're also reinventing how we deliver training. And so our recertification requirements have been filled traditionally by 1 week, 36 hours of solid block every 2 years for our providers to have a cram so that they would study everything that they needed and then take a test right afterwards, sort of a binge and purge bit. That's not a model of education that is favored, and so we've moved to the modular program, and thanks to the Department of Health for allowing this to happen. What we're doing now is we're doing 4-hour blocks over a 2-year period. So it's a much more preferred method of learning. Along with that, we've last year had a enhanced trauma training at Howard University Hospital. So we sort of began partnering with the medical schools and university hospitals that are in the area to do this. As part of that, we actually had a baseline assessment of our providers. And so it was specifically on trauma, but we're using that baseline assessment to inform further training. Next steps for training. We have a plan for this year, enhanced pediatric emergency training. I'll just hold that back a little bit. In partnership with Children's National Medical Center, where we're going to have for our ALS providers a mandatory day where they'll spend 8 hours in the emergency department at Children's. Half the day will be spent with their providers doing acute asthma care, and then they'll be doing pediatric triage in the emergency department. And this was really informed by a survey that Local 3721 provided with small numbers, yet it really showed that their survey respondents indicated that they felt less at ease with pediatrics. And I think that mostly reflects that there are substantial members that actually work in houses that don't serve a lot of pediatrics, let's say in the center of the city. But nonetheless, we thought this was important enough to address, and so that's what we're rolling out. Excuse me. We're also going to be doing paramedic grand rounds, where we're having quarterly this year, 4-hour detailed symposia, where we're going to have this conducted in concert with local medical schools and teaching hospital faculty for our ALS providers. The first one rolls out at the end of March. And for our BLS providers, we're rolling out in the next few weeks company-based, case-based education, where in their station houses, the company officers with the team of 1 or 2 ALS providers, or mostly BLS providers, will be going through these cases. And as part of that, there'll be opportunities to pause and really inquire in these small groups how the BLS providers are thinking. So we're trying to develop their critical thinking skills. This is also going to provide a team building exercise, and we hope we'll be developing an environment where the ALS providers will feel free in that session, but throughout their work life together, to really encourage the BLS providers along. So, that's that. Okay, next slide. Integrated Healthcare Collaborative Report was released last week, and you have copies with you. And Washington, D.C. has the highest per capita 911 calls of any city in the country. And 48% of our calls are for low acuity medical reasons. And so I think we recognize that we needed to have a strategy where we really could direct these patients away from the emergency transport system and away from the emergency departments to a more appropriate outpatient care setting. And so since last April, we gathered a very large group, almost 60 people participated, interagency, but also governmental and non-governmental partners. And we had 5 committees that are listed on the slide there. We thought that the way to do this was the institution of a nurse triage line. We need to come up with an alternative way of transportation other than red lights and sirens for people with sore throats and bladder infections. And we also needed to establish a destination, a non-emergency department destination where they can go. And so one of the committees was called Connection to Care, and it identified 16 to 18 clinics throughout the city that could actually meet our criteria that Dr. Nesbitt and I came up with, that they had to have an ability to accept all insurances, including individuals who could not pay and did not have insurance. They needed to have extended evening and weekend hours. They needed to have a patient-centered medical home with a portal. And they needed to have on-site behavioral health, social services, and case management. And so we were very happy that we were able to identify those. If you look at your IHC report and just look at the last page, we've replaced that blurry image with an insert, which the insert is, I'm hoping, is in there. Oh, great. Okay, so the insert that you have, if you look at our low acuity callers, they really skew towards east of the river and east of the city and in the center of the city. But there's a geospatial map on the previous page that you have in your left hand that looks at where these calls are coming from. They're not coming from the northwest. And so the nice thing is, when we looked at these clinics, which are mapped there for you, they actually juxtapose beautifully as to where the patients are calling from. So what we're really happy with is that we have a destination of comprehensive primary care with all of the features on our wish list that's located very close to where the callers are calling from. And so we've been working with DC Primary Care Association to really determine and partner with all of these clinic systems to make sure that they have capacity for upwards of 200 patients a day that would be taken out of our emergency transport and emergency departments and placed into a clinic system. And so we're continuing that partnership with those agents, with those clinics now. And so we anticipate, as we get close to the launch of this, that we'll have to let them know a few months in advance so that they can up staff. Okay. We've also had to amend our own patient bill of rights, which says if you call, we haul. And so we're going to be able to say, if we've assessed you in the field that this is not an emergency, it's not life-threatening or limb-threatening, and we can take you safely to another destination. As part of this, we're also going to have a lot of public education about this. We realize that. So that's it.
That concludes for us, Mayor.
Thanks. And thank you, Chief, and thank you, Dr. Holman and Director Holmes, and also Director Nesbitt, who have all been critical to the to the changes that we've made at FEMS. And I think what you see at the Integrated Healthcare Collaborative Report, they just concluded their work last week, and now I have these recommendations to review and make some decisions about how to proceed. I'm happy to answer any questions.
Other questions from members? Councilmember White?
Thank you. Thank you, Chief Dean, for the work that you're doing. I have a couple just clarifying questions on slide 5 regarding ambulance response times. I think you had mentioned that the reason that the response times are still a little slower than you'd prefer is because these are places that are further away from the hospital cluster. But these are response times and not drop-off times. So what's the correlation between the location of the hospital and the time it takes to get to a patient?
So the correlation is that previous, when you look at the slide on the left map, is that most of our units were out of position because we were responding to a lot of calls. Now that we're able to keep our units within their first response district, we're seeing an improvement, especially east of the river. That's what this slide is showing you.
I see. Thank you. Somewhat along those lines, page 10 on the drop-off times. Do these times include, and you might have said it and I missed it, do these times include the wait time at the hospitals?
Yes. So the drop times are from the time you get to the hospital until you put yourself back in service. And so working very closely with the hospital staff to try to get our units there. What'll happen, especially during busy times, is that everybody's in the queue as they try to get beds ready. The ideal of the Integrated Healthcare Collaborative is to reduce the number of people we have in the queue so that we can get our units in and out of the hospital in a timely fashion.
All right. Okay. Last question. You mentioned some of the things that we're doing to reduce the burden on emergency services for 911 calls, and I understand why our call volume is so high. People are calling it for non-emergency reasons, but do we have any understanding of why our call volume, 911 call volume, is so much higher than other jurisdictions? What's different about DC than other jurisdictions?
So, Director Holmes,
So what I've seen and witnessed and had conversations with other jurisdictions is kind of two-parted. So the district is unique because a lot of jurisdictions, for instance, in Dallas, there are multiple cities around, so there are multiple PSAPs, so some of the weight is shared. Other jurisdictions have the city PD department or the city fire department, and then you also branch out and then you get into the urban area. So there are multiple PSAPs. Being that the district is local, state, county, we have one PSAP.
What's a PSAP?
Oh, I'm sorry. I'm used to being around my cohorts. It's Public Safety Answering Point. It's a 911 center. And so we pretty much only can rely on ourselves. You have other jurisdictions and states that they're able to share the call volume with other 911 centers. And then the other thing is, of course, we had the influx of a population during the day that almost doubles our population, and so that goes into account. And I wouldn't say that this struggle is not being shared by other larger jurisdictions like Chicago or New York. It's there also. And I think with the IHC report, one of the bigger things is also just public education about when to call 911 and when not to. And conversations we've had before with Chief Dean, the mayor, Dr. Holman, is you don't want to tell people not to call 911 unless you give them options, right? What else can they do? And I think that's what we've tried to do here with the IHC. You're welcome.
Councilmember McDuffie.
Thank you very much. And thank you, Chief Dean and Madam Mayor and all your team for the work that you all have done over the last couple of years on this. I also want to thank my colleagues because a lot of what we were doing in the Judiciary Committee last council term had to do with just these issues and the commitment that Chief Dean put in place to reform EMS and work with community partners. We're seeing the headway, and I wanted to just commend you for the work that you've done there. The work that you've done with decreasing the drop times, I think, is also notable. The increased engagement with community partners, the pediatric training of our providers, which was a major concern over the last several years, I think is all something that we should be, I think, giving due credit for some of the improvements that we're seeing there. I did want to ask about the And just to also note, and I know some of my colleagues who were on the committee last year remember, we actually helped to establish this task force. The council did in our budget last year, and so we're happy that things have played out this way, and we're seeing some of the great recommendations. In terms of low acuity and the patient transports, it appears that in the increased call volume, I guess I should ask it, the low acuity calls, are they also increasing in terms of the call volume that we're seeing increase? And the transports of those patients?
It's probably hard to measure. We're seeing an increase in call volume. We recognize that the majority of our calls, we think about 200 of them can be pushed to the nurse triage line to be able to handle those type of calls.
You said approximately how many?
About 160, let me get that right. About 160, we receive about 500 calls a day.
Okay.
And out of that, we think that about 160 of them can be pushed on the nurse triage line to be able to take them out of the 911 emergency system. Again, everybody will be allowed to call 911 because they may not know. We will make the determination based on our answering protocols as to whether what resources we should send to take care of what their symptom is.
And the whole idea, I know one of the concerns that was raised by colleagues last year with the call volume is sort of the resources that it takes to provide the services to those folks who perhaps don't need to be transported to the hospital. And so in terms of, and maybe I should try to ask it a different way, is there a way to determine whether or not those types of calls have actually decreased in everything that you've measured?
So over the last few years, the low acuity versus high acuity calls split has remained relatively constant.
Okay. And so in terms of some of the work, and one of the reasons that we introduced a community paramedicine bill that eventually got incorporated into the budget was to try to figure out how to decrease those types of responses and the resources that you have to allocate in order to deal with that. And so is the idea that at some point you will see fewer people calling 911 when they really don't need to call 911?
Again, I think the Integrated Healthcare Collaborative, that's how they're addressing this. Because when you're at home and you're feeling sick, you call 911 and then they help direct you to the right resource. So I don't know that we would see a reduction in the call volume. It's just what our response would be to that call. Currently, we send red lights and siren for every call, and we're saying there are better ways to utilize our resources as well as what happens at the emergency rooms and other places. So the IHC coming out of your committee is really addressing those concerns.
Okay, and then I think I saw some of it, but I didn't get one of the handouts till a little late, and so I wanted to ask, in terms of the ALS response, initially there were still some concerns by some of the providers that there were ALS responses to otherwise calls that otherwise should be BLS responses. Have we seen a decrease in the ALS responses?
Yes.
With respect to AMR and there?
Well, we've seen a decrease from 23% to 18% of our ALS providers handling BLS calls. We're continuing to work on that. One of the reasons we're adding more medic units is to be able to address some of those concerns at the same time. We're also continuing to look at our protocols. We're looking at how we dispatch. It'll be it's ongoing, but we hope to see improvement just like we saw with our BLS as we continue to concentrate on this problem.
Thank you.
Councilmember Allen.
Thank you, Mr. Chairman, and thank you to the chief and to everybody for your work on this. Just as a quick reminder, we have our oversight hearing on Thursday, so anybody who would like to come will certainly take questions there. I will. I just wanted to make a couple of quick comments, and then we'll talk more deeply about this obviously on Thursday. But I think what you are helping engage in is nothing short of a systems change completely. And I want to acknowledge, too, the work of Mr. McDuffie and the committee previously as well, because I think that helped in collaboration lay a lot of the groundwork, and I really also applaud the work that you're doing so far. But it is nothing short of systems change. We've talked for 20 years at least about frequent flyers and what the impact is across the entire system. And what I appreciate, Dr. Holman and I have gotten together to talk about some of this is not just, of course, where we're looking for emergency medical management, but also what that linkage is back to your medical home and to your primary care provider, ultimately trying to get at that systems change. So I just applaud that work. And I think it's worth noting that the gains, while I think the Chief, you have lauded a lot of the gains, but also I've kind of heard you couch them some a little bit as they're a little more modest than you want them to be, and you keep pushing. I think it's important to note, though, that's in the face of ever increasing calls for service, about 9,000 more calls year to year. So those gains, I think, are actually greater than they appear on the surface because the calls for service continue to go up dramatically. And I think one of the biggest parts that we're going to also get out of this, of course, is the training. And Dr. Holman, we've talked about that, the training that you're doing across the board, but the training, changing the way that we do it completely. I agree, the crash course every 2 years to a much more thoughtful and engaged way that I think is actually more sustainable as well, and creates a greater impact. The nurse triage, the thinking through transit in a completely different way. All these things are going to get at the systems change is what we're aiming toward. And so I look forward to the conversation we'll have on Thursday during the hearing. I just want to, again, thank you for the hard work that you're doing here in laying out this case, and look forward to deeper conversation and continuing the progress. Thank you.
Thank you.
Councilmember Bond?
Well, I just really wanted to, I guess now, add my voice to the chorus of saying this is tremendous. And I mean it because, as Councilmember McDuffie indicated, we were a little concerned a few years ago, and this is a total new system that we put in place. We commended, and to hear that we're now going to talk about referring people to neighborhood clinics. This is really exciting. The training is right on time. I think that the community will greatly embrace the new fire and medical emergency service system. And I just wanted to say that. Just have one question, and that is about the delay that remains at the hospitals. And you indicated one of the big issues is the bed, the rollout. Just wondering if there's a way to have a collapsible rollout that can come in place when you roll one out and then the other, so that the patient can really be attended to at the hospital, and then the vehicle can move on to the next location. Just wondered if I'm sure there's some lineal,
Well, not sure what they've invented yet, but the answer is that it really is patient care. So having somebody to actually take care of the patient, and really the work that and I appreciate your kind words. The work that Dr. Holman has done in this integrated health care will reduce the number of people that are going to the emergency room, which will free up beds so that we can continue to do this type of work and get them in and out in a timely fashion.
Well, thank you. And Mayor, this is a job superly well done.
Thank you. And to your point, and to the team who's really been focused on this, council member, when we see the people who don't need to be on an ambulance, it also means they're not, and they don't need to be in the emergency room either. So all of these things are linked together. So when we get people out of the ambulance and in the right vehicle to the right location, we know that we will have the most emergent cases show up in the emergency departments.
Councilmember Che?
Thank you, Mr. Chairman, and good morning, everybody. Thank you for this report. It's very positive, and we welcome it. I just have one question, which may transcend what we're directly talking about, but it's related to it. You had mentioned, Chief, that what we want to do is when we redirect folks, we want to have these other opportunities for them to get care, and they have to meet certain criteria and so on. It may be in here, I don't know, but what are we doing to make sure that there are enough of those alternative places, particularly in places like 5, 6, and 7, where hospitals are few and far between anyway? Is there any plan on that end?
Well, I wonder if Dr. Nesbitt would like to answer that.
So, as Chief Dan mentioned earlier, we did an assessment in terms of the connections of care and the capacity in the city to be able to support some of the low acuity patients who show up in our emergency departments. Over the past 5 years, the district itself made an investment of $70 million into primary care, which included increasing the capacity of our primary care system to support many of these patients. That capacity, which I personally participated in back in 2010, has been developed and not well utilized. So we have an underutilization of the primary care capacity in the District of Columbia that we often don't talk about. So when Chief Dean talks about 160 low acuity patients who could be diverted into the primary care system, we do have the capacity to move them into those locations, which are, for the most part, in wards 5, 7, and 8. What we have to do is do a public information match to get our patients to understand that they can utilize those facilities, those primary care centers. We have to work more collaboratively with the managed care organizations to make sure that they are managing care. Many of them do provide those alternative transportation options. We have had conversations with them, many of them participating in the IHC to make sure that same day and next day transportation is available. So their capacity is absolutely there. We also will be assessing the district's capacity for urgent care, which to date has not been well defined. We only have, by certificate of need, 2 urgent care centers who have a certificate of need, but as Dr. Holman mentioned, there are places that are open until 10 p.m. and available on the weekends to be able to accommodate many of these low acuity visits, which tend to peak, I believe, around 2 p.m. In terms of call volume when many of these practices are open.
Thank you.
Councilmember Todd.
Yes, thank you, Chairman, and thank you, Mayor Bowser and Chief Dean, for your focus all across fire and emergency management services. I just wanted to note on slide 7 my particular interest in your focus on rebuilding the fleet management. Certainly, I think it's important for DC residents and Ward 4 residents to know that we have the tools to do the job. So I'm very appreciative of your focus on fleet management. And I noticed that you plan to procure a number of additional trucks this fiscal year. Can you talk a little bit about what your plans are even beyond now?
Well, we have a plan for apparatus replacement, and it'll continue to go into the future because as we run these vehicles pretty hard. We have to, they have a 6 to 10 year life, so we will continue our apparatus replacement plan, which will allow us to have a reserve fleet where you can take these units, you can run them downtown where they have a high call volume, move them out to the neighborhoods, then put them in reserve, and that'll allow us to progress through our apparatus, use them to their full life, and still be able to, when we have to do a major rehaul or have an accident, have units in reserve so that we're able to maintain a full in-service fleet at all times. That's really what the goal is here.
Excellent. Thank you very much. Appreciate it.
Thank you.
Councilmember Silverman.
Thank you, Mr. Chairman, and thank you very much for the presentation. I do think it's really significant to hear the reductions in dispatch times, Dr. Holmes, which is a big issue last year. It's quite significant. The training, it's really thrilling to hear that a reform actually worked. That was the whole point of bringing in the AMR ambulances, is to free up our responders to get the training, and certainly the ambulance availability is very significant. I do want to ask just 3 quick questions. Number 1, the correlation between calls and population. Is that a 1-to-1 correlation? In that, have we looked at areas of the city that have seen that increase in population, and are we seeing an exact correlation of call volume, or is the call volume increased in specific areas of the city, which then will require specific strategies, let's say on education, that might be more tailored toward the specific needs of those areas, whether it be that they're unfamiliar with how to access primary care, or they don't have transportation. Like, have we looked at this at all?
We've not looked at it in that detail, council member. We're looking at it in the way of saying that we were going to start with educating the whole public, because the types of calls that we're receiving say that district-wide we need to educate everybody. But I think as we continue to refine this, we can include that part of it too, to take a look. We haven't looked at population growth as to where it's coming from. More so, we've looked at population growth and the impact it has on the resources that we have.
I hope to participate in the oversight hearing, but maybe just as a data request, I think it would be interesting to look at that, because I imagine different people are accessing 911. Not everyone's calling 911 for the same reason. Some people do have primary care. Some people don't realize they do, or, I think that would be interesting. I guess that's just a request.
Okay, and we'll take a look, because maybe the IHC, the Integrated Healthcare Collaborative, was looking at that, and that's why they were saying that it matched up where the urgent care facilities were with our call volume and everything, so we may be able to answer all those for you.
On paramedic training, do we have a paramedic training program in the district? Like I noticed that you mentioned that we have a 90% district hire rate of our BLS, I guess, responders, but how do people get ALS training? I guess I'm thinking about this in terms of workforce development.
So currently, we train people to be EMTs for our BLS. We hire people as paramedics, so we do not do the paramedic training currently in the district, and so they go through the National Register and other programs to become paramedic.
Okay, and on the you call, we haul issue, that would be a legislative change that we would need to make to the Patient Bill of Rights, or how do we amend the Patient Bill of Rights? Is that something that's done by executive order?
If I'm not mistaken, when we looked at it, that actually it does not require any legislation. It is something that we put together, and it requires all of us to. But our goal was to share what we came up with, so that we're all in agreement. We think that the integrated health care and other things that we're adding do not take away any rights. It's just a matter of allowing the responders who go there with medical training to make medical decisions, versus just to go there and take the patient regardless of whether they need to be taken or not.
So this will be an administrative change made by FEMS?
I believe so.
It would be made by me.
By the
Yes.
mayor? Okay, great. Well, thank you. And once again, I think there's a lot of great news in here, and congratulations to everyone who's worked very hard on that.
Thank you.
Chief, I have two quick questions. First, you mentioned that you have a new staffing model, a pilot with Local 36, but that you already had a pilot with 3721. It's a single role EMS folks that you put into, I guess, permanent practice. And that is for the 3721 personnel to work 24-hour shifts. Did I understand that correctly?
Correct. So 3721 personnel used to work a two days and then 2 nights and 2 days to get to their hours.
They work 12-hour shifts.
They work 12-hour shifts. Yes. So we switched them. They requested, and we tried to pilot moving them to a 24-hour shift. So they work the same schedule as the 36.
But Chief, there's a lot of research out there that says that the quality of care diminishes over 12 hours, which is why I've always heard best practices no more than a 12-hour shift. So how do you reconcile that?
As me and you've talked before, I came from a system, Seattle, that had a 24-hour shift, and we were not seeing the quality of care issues. As I would demonstrate here in the district, a lot of the issues that we previously had, we have been able to address those. Again, it is the members recognizing and accepting their responsibility. It's the training that we're providing them, and it's ensuring that the call volume increases, is that they come to work prepared to work. And so we don't see those challenges. Again, I know there's studies out there, but we're not seeing those challenges.
The other question I have follows up on Councilmember Silverman. A few years ago, there was the department said that it was going to work with the community college for paramedic training. Is there anything underway in that regard, or any discussions?
So we currently we are working on stabilizing our paramedics and getting their training. Long term, what I would like to see is us working with the universities, where the training would happen at the universities, research hospitals, where they have all the doctors and everybody's available for the training, more so than the community colleges.
That tells me that there aren't discussions right now.
There have not been discussions since I've been here with the community colleges. We've been hiring since I've been here from people that have already have paramedic training. The program that they talked about that they had at the college is no longer there. The closest one is over in Maryland.
But we're happy to look into all manners of training with UDC for our personnel. And so we have the Cadet Academy set up, but I see it also as a connection that we can make with the Cadet Academy.
Madam Mayor, there are no other questions from council members, so if you want to move on to the next item.
Sure. So I think
Thank you,
next
Chief Dean.
we're going to hear from Councilmember Evans.
Okay, thank you. I wanted to make sure everyone has their Metro update, and I'll have a presentation in 3 parts. The third part will be by Jeff DeWitt, our CFO. So, part number 1, we are currently, Metro has a fiscal year that is July 1st to June 30th, unlike the districts. We are currently in fiscal year 2017, and we have currently gotten our first half results, and they're not good. Ridership continues to plummet, and we are $65 million less revenue in the first half of the year than we thought we would have. Extrapolating it out, it looks like we're going to have a $125 million shortfall for 2017 because ridership is predicted to continue to fall. The general manager assures me he's doing all he can through management actions to close that gap. Does not anticipate having to come back to the jurisdictions, but time will tell as we get further into the fiscal year. Secondly, the year we're working on now, 2018. As you know, the budget, after all was said and done, is $290 million short. Again, there are 5 ways to deal with a shortfall in a budget. The first is management efficiencies again. General manager has taken a number of actions, including reducing our workforce by 1,000, either positions or people. And since I'd say about 75% of Metro's budget is personnel, that's the area that we have to address. And really tightening up a number of other areas where Metro has not been good at in the past. Second way is jurisdictions. The jurisdictions were asked to and did agree to contribute 10% more this year than last year. Maryland and Virginia have made it clear that they will not contribute any more toward the $290 million shortfall. Capital dollars, we are already taking $60 million of capital money that should be used for capital expenditures and using it for the operating budget in order to try and close the gap. Now we're down to 2 other areas, fares and service. So it does look likely we will have a fare increase, and it does look likely that we will have service cuts. The dates, March 9th, next Thursday, is the final Finance Committee meeting at which the General Manager will present his recommendations, and then March 23rd, Metro will vote on the final budget. So that's where we are in 2018. Beyond, it's a grim picture. We have to have certain things occur at Metro over the next 18 months to stay afloat cash-wise. We have to extend our lines of credit beyond the $250 million that we have now, because that'll all be borrowed out for another $100 million. We have to get $150 million of federal grants that have been owed to us since 2010, which we're trying to get. And we have to borrow long-term $575 million. If we cannot complete those 3 transactions, Metro will run out of money. And I want Jeff to address the request that Metro is going to be making for 2019. There will be a significant increase in the requests from the 3 jurisdictions. It will be on the operating side, it will be significant. On the capital side, it will even be more significant. So I leave everyone with the thought that we've always had, and the district is good on this. Metro will not survive without a dedicated funding source. There is not enough money in the jurisdictions to allocate on the operating side and on the capital side. as we get to 2019. And when I say it, people kind of don't listen. When Paul Wiedefeld says we are at the cliff, people do start to listen. So Jeff, if you want to give your presentation on how...
Follow up on the cliff.
Yeah, to follow up on the cliff.
Yeah, it's hard to follow the grouper on that. I'm not really sure what to do with that. But just to give you an update on some of the things that we're doing with the jurisdictions, my staff and I have been working on some modeling and a presentation to the Council of Governments. We'll be meeting with the city administrators, and we've had some discussions with some of the finance folks at those jurisdictions about what that long-term gap is and how to bridge it. And that is an update from what we presented to this body at this meeting a little while ago. We now have their capital needs inventory and their state of good repair updates that we're now reflecting in. And we now know what the 18 budget is that Councilmember Evans was talking about, the $290 million gap that's there. So we have a lot more updated information to determine what the long-term needs are from a dedicated funding source or significant contributions from jurisdictions, or let Metro continue to decline. I mean, those are sort of your three difficult choices. In terms of, and so that will be, we'll discuss that, get an agreement and consensus amongst the jurisdictions about what are the right assumptions going forward. What is the agreement on what the state of good repair should be? I've had discussions with Metro on almost an every other day basis here in the last week as we prepare to have that discussion. So we can all get together, Virginia, Maryland, the District of Columbia, and the counties and cities, in terms of what are the challenges that we're looking at. The first phase of getting something done is agreeing on what this magnitude of the challenge is, and I think we're close to that. In terms of the other things that Councilmember Evans talked about is they do have cash flow challenges. The choice is either we, all the jurisdictions would have to come up with money, or there's short-term borrowing options. Those are not great options, but they are. It's not that different than what we and other places have done, where you borrow short-term to cover your cash flow purposes, but you have to pay that back. So even though there are mechanisms to get them through their cash flow challenges, it is more the longer term, the 2019 impact, the long-term capital needs, how much do you need to repair, that we're looking at. So there's a lot of work being done in terms of their solutions for cash flow challenges that was mentioned in terms of letter of credit expansions and long-term borrowing that they need to do anyway at some point, but their ability to do what they need to do is not sufficient without a dedicated funding source. They can't borrow the billions that they need without a dedicated funding source, so it's just an issue that we're all going to have to understand, or you don't fix it, the situation it's in. So we're long-term capital, long-term operating capital gaps, the 2018 budget that was discussed, and then the cash flow management are all things that we're working on, and discussions of how they manage that so that the system keeps running. I think there's ways to do that, but it's not going to come out with some long-term cost. If you recall, back in the end of November, I sent a letter out to all of you showing what the gaps were on the operating capital from the last year's budget, and the $37 million gap is what we're going to need to fund to get the 2018 request from Metro in, which I know that we've been meeting with the mayor's staff and been talking about that in terms of the base budget for 2018. And then, but the bigger challenge is really the capital. How do you fund the capital side for 18 and 19, while you hopefully take efforts to get to a dedicated funding source. And I do want to thank the mayor for her leadership with with the other jurisdictions and pushing that dedicated funding source forward. And just to put it in an order of magnitude, it's a couple billion, and I use the B, a couple $1 billion for each Maryland, Virginia, and DC over the next decade that is the gap, not what we're funding, but we don't have, none of the jurisdictions have a dedicated, have any funding source identified for. And to put that in perspective, the mayor's budget last year, the one the council passed last year, it was a $6 billion total CIP, so that's 1/3 of our capital needs is the gap. That is that we're looking at for just our jurisdiction. It's similar in Maryland and Virginia. So it is something that we're going to have to put some effort into to figure out how to fund it, or what absolutely has to be done. We don't want to put any more in than we need to, but we also it is also critical, from my perspective as a CFO, we're going to be releasing a forecast later today. We're finalizing it up for the February forecast that drives the 2018 budget. And you're going to see it's going to be a very positive forecast. Things are going very well in terms of the economy in the district, from the hospitality side to the to income tax to property taxes. Everything are positive, but that's not sustained if you can't continue to grow. So Metro, in my perspective, is someday in the future that will start affecting our forecast if it's not dealt with. So I don't know if that's what you're looking for.
No, that's good, Jeff. So to summarize, just looking forward, not today, but looking forward, Metro will be asking, if nothing changes, and I have no reason to believe things will change. Since 2006, we've been talking about a dedicated funding source. It's now 11 years later. If nothing changes, the ask from Metro on the operating side will be 30, 40, maybe $50 million more next year than this year from each jurisdiction. And as Jeff pointed out, $2 billion in capital money. That's what we would need to continue to operate the system and to fix the system with nothing changing. And so it's a very bad situation. So that's it.
Questions from any members?
Let me just, if I may, let me thank Jeff and Jack for all the work that they've done. Jeff continues to be, in my view, the person who knows the most about Metro's finances from all of the jurisdictions. And 2 years ago, we had a similar conversation when we knew that Metro was having cash flow issues. And Jeff worked with their CFO and all of the CAOs from around the region to talk about getting over that hump. They're in a similar, we think, issue with cash flow, and likewise, we're working with them on how to meet that short-term, long-term, and cash flow issues that they're facing. I want to say something that sounds a little strange, but I think it was a good sign to me when the new Secretary of Transportation halted regional money to Metro. Now, I said that sounds strange. And for us, we were the least affected. Even though we were already ready, we had the bill in place to create the new Safety Commission, we were still impacted by $700,000. What I thought was a good sign, however, is that the whole state of Virginia and the whole state of Maryland was affected even more. So not just the jurisdictions that surround DC and rely on Metro, but all of their transportation for the whole states were affected. And the members of those legislatures, she got their attention, that they can't kick the can down the road on the Safety Commission and on other issues involving Metro because federal transportation and transit has the ability to affect the whole state. And I thought that was a message that said the system is important. We're going to hold you accountable to what you promised the U.S. DOT. And if you don't, we're not just going to affect Prince George's and Fairfax, but we can affect the Eastern Shore, and we can affect other parts of the Commonwealth of Virginia. So all of us, and I know the executives in those states will say that they're working to get the Safety Commission language. We hope that we think that they did it, both?
Virginia passed.
Virginia passed, and Maryland is still in session. And so they're on track to pass. And so we think all of the federal funds will come back. But it's just an indication that not only the close-in suburbs of Maryland, Virginia, they've been trying to carry the weight for this dedicated funding system, but the whole state, both states, need to contribute to the solution. So we will continue to press on all parts, including with the people in the federal government who recognize that Metro, of course, is our local transit system, but it also carries a significant number of federal employees and millions of visitors that come to the nation's capital. So they have a unique position and unique relationship with our transit system. So we continue to plan and try to remain nimble in our budget planning, but the capital, the difference between not having a dedicated funding source and our ability to plan for our capital needs is tremendous. What Jeff has laid out is if we have those dedicated revenues to borrow against, we can actually get there. And I don't remember the end year, but in a very short number of years, with the ability to borrow against those dedicated funds. Without doing it, coming back to the jurisdictions from $2 billion is just perfectly unsustainable. So we will continue to press on those issues. But Jack, I do want to say that I think we've all been pretty stunned by the decline in ridership because I think that they are very off of Metro's projections, even from last year when SafeTrack was introduced. What is the general manager's or what is the board's thoughts around these ridership declines?
Reliability comes down to that, and SafeTrack has proved, because of its construction, to make it even more unreliable than it had been in the past. Not surprisingly, because we're closing down lines and causing all kinds of disruptions. The big concern is, though, is the ridership going to come back? And with the alternatives out there now of working from home, Uber, Lyft, other means, bicycles, other means of transportation, there is a concern that they use this term called new normal. So is there a new normal now? That the ridership on Metro that we have today is the ridership Metro will have into the future. If that indeed is the case, that does not bode well for Metro because we rely on getting riders back in order to make up some of the financing. But let me say this. In our calculations, if every rider, the last time we had a ridership increase was 8 years ago, and then it declined for the last 8 years. If every rider who left our system 8 years ago came back, we would still not have near enough money to operate the system or to repair the work that needs to be done. So ridership is a problem, and it's a short-term problem right now, $125 million problem. It'll be a problem next year. But again, remember, ridership is not what drives Metro. The operating budget of Metro is about $1.8 billion. We get $900 million out of the fare box from riders. The other $900 million comes from the jurisdiction. So ridership going up does not in any way, shape, or form begin to address the finance problems that Metro has. But your point is well taken. We are losing riders, and until and in the surveys we do, it's not safety, it's not even cost. It comes back to reliability. I want to be able to get on the train here and get off here and get to work on time. And if I can't do that, I'm not riding it. And right now, we cannot provide the assurance that we can get you to work on time.
Councilmember Allen, you had the question.
Thanks. Well, I appreciate the comment. Thank you, Jack, Jeff, and the mayor. You know, when we look at this, I am proud of the fact that at least for the district standpoint, I think we're doing our job. You know, I think from top to bottom, the commitment, Jeff, your hard work of trying to make sure we dig into the finances, I think has been very helpful. And I think it has helped push Virginia and Maryland where they need to go. And I'm proud the district's been a leader on this. Two comments, maybe there's a question in there. First on the ridership, I've talked about this before. I think that WMATA does a wonderful job of telling people to stay off the rails and to get away, and they do a horrible job of telling people to get back on the system. And I think that impacts our ridership numbers, and I do think that impacts the perception of your ride. And we've talked about this before, and Councilmember Silver and I both talked about this. When we constantly bash Metro and talk about how horrible it is, for those of us that ride it on a regular basis, we do damage to the system by constantly telling people how horrible Metro is. And so we have serious problems that need work and addressing, but I do think we should be careful about how we talk about Metro and the perception that we create, because it impacts our ridership. Secondly, it has to do with the fares. I think that no one likes to see a fare increase, but I think the reality is that there's going to be a fare increase. We've talked about it before, but I want to make sure I register it again. The fact that we are going to have the base fare increase of the rail go up 10 cents per ride, but the base fare for a bus go up 25 cents, I think it's way out of line and out of proportion. I think it disproportionately impacts the district ridership and our residents. I think it disproportionately impacts people who are transit dependent. Not everybody lives next to a Metro rail station, but district residents and our neighborhoods are connected by our buses. and a 25-cent increase on the base fare versus a 10-cent increase fare on the rail, I think is disproportionate. I think it'll have an impact. I said at the very beginning of Safe Track, my fear was that we were going to try to fix the system on the backs of our bus system. And I think this fare proposal just confirms that. And so it's frustrating to me. I hope the board will consider trying to think through ways to do that. To your point, Mr. Evans, the fares aren't what will save the finances. It's an important part of it. But it's the investments we make as the district, and obviously, hopefully, with Virginia and Maryland coming on board too.
And Charles, I don't want to get too much into the weeds on this. On the bus side, and I completely agree with you and have argued that point, one of the issues we're considering, and you have to be a bus rider to really follow this, if you buy a 7-day bus pass, your fare will remain at $1.75. But if you ride the bus and just pay as you go, what the contemplation is, it would be $2. The idea is that would benefit people who ride the bus on a regular basis, and they would not have a fare increase. For what it's worth, that's one of the discussions that they're having.
I appreciate that. So you're saying most people riding the bus, that's how I get home, you use your smart trip. So you just tap it and you go.
Yeah.
So that you would not see a fare increase. It's for your one-time bus ridership. That's
You
it?
can buy a pass
weekly pass
on your smart trip.
A weekly smart trip pass. You would not see a fare increase. Right. If that makes sense. I'm not as well versed in the buses as some people, but that's it. Yes.
Okay. Well, I'm glad the board is looking at that.
Yeah.
That's what you're describing, is that you're using your smart trip or you're using your pass. You're not seeing a fare increase.
Correct. Yes.
That's what you're proposing, Jack? 'Cause
Yeah,
that
for
wasn't
7
part.
days.
That wasn't part of the. I don't
Correct.
think that was part of the hearing
No,
discussion.
it's not. That's a new idea. Because myself and the Prince George's County rep are the two bus people.
So I'm just making sure I understand. You're saying your smart trip card, the thing you load your money on, or are you saying a 7-day pass?
7-day pass. It's a 7-day pass.
I believe you can buy the pass and load it on the smart trip.
Yes. Yeah. But again, now you're into technical things that I don't really know.
Yeah,
But that's, unless you're a good bus
Oh,
rider.
no. Well, I think as a regular rider, most people just use their smart trip card.
Yeah.
Right, so you can be a daily rider. I'm sure there are people in this room who are daily riders and they're not buying the bus
I'll
pass.
check
So it
into
doesn't
that.
capture
Gotcha.
that population.
Gotcha. Now I understand the issue. So I'll check in to see if we can make that happen.
Yes.
But I don't think you're saying different things. I think
No,
you're saying, I believe that the passes, they have many passes still available,
Yeah, okay,
that you
good.
can buy the pass and load it on
Load
your
it on your
smart trip
smart-
card. So it's not
don't
something
know.
different. That is something different, but it's the same fare media.
I'll find out.
Okay. Thank you, Jack.
Kenyon?
Thank you for the presentation. Jack, I think I CC'd you on a letter that I sent to Paul Wiedefeld about 2 or 3 weeks ago.
Yep.
There are a couple of issues. This wasn't on the letter, but I know that I think Councilmember Todd and there's another part of the city that is having concerns with the rumbling and the vibrations in the
absolutely.
homes. We're similarly having that concern with residents along Gallatin Street, North Michigan Park. And I've been to the homes, I've felt it, I've heard it, and it's real and it's serious. And so I want to just put that out there so that folks are aware that there are multiple parts of the city that are affected by this. The other issue is more relevant to the discussion about funding and cuts and things like that. I recall when Paul came to our breakfast several months ago, I asked him because we were doing Safe Track. I think there was an expectation that the ridership on the rail would go down, but I asked him, is there a correlation in ridership going up on the bus since people can't ride the train? He said, no, actually that's going down too. So with the increased in cost to bus rides, it's obviously a concern, but then this notion that there's going to be proposals to cut routes on buses as well. One of the routes that they propose to cut, actually two in Ward 5, is the B8 and B9, which travels to parts of Ward 5 that have a heavy concentration of senior citizens. And so I'm deeply concerned about that. The letter says as much, and I'd like them really to revisit that. I know costs are obviously an issue, but they're proposing to use the G9, which is a new route that the council funded last year, and thanks to all of you who supported that, G9 going up and down Rhode Island Avenue. Now they're saying we're going to expand that and send that to some other parts of the city because we want to cut these other routes. And I think it's going to essentially make the G9 not even serve the purpose and the intention of what we had designed it to do, is to service a particular area of the city. where the G8 was already overcrowded. So please look at that and help with that, because my residents are deeply concerned about the plans there.
Okay, great.
I don't believe there are any other questions from council members. Oh, Councilmember White.
Thank you. Jack, I really appreciate how much work you're putting into the Metro Board. I'm a little unclear on the end game. So I think you just said if ridership goes back up, Metro will still be operating at a significant deficit. It seems that Maryland and Virginia are not particularly interested in subsidizing the system. And so even if we get to this state of good repair, the system still has to be subsidized. So from the perspective of the board, where are we hoping to get? I mean, what are they hoping to end up with?
It comes down to a couple of options. I mean, in the best of all worlds, we would get the dedicated funding source. And I think you're right. Maryland, the mayor hit the nail on the head. If it was just up to Montgomery County, Prince George's County, and the 5 jurisdictions in Virginia, we'd probably be able to get there. But in Maryland, the money is controlled by the trust fund for the state, and the rest of the state just isn't interested. Virginia, same deal. In order to raise taxes, sales taxes in the 5 jurisdictions in Virginia, Richmond has to give them the opportunity to do that, and they won't do it. So it really does put us in a terribly precarious position if they are unable or unwilling to do the dedicated funding source. The federal government is another option, which we are making inroads at, but with the Congress we have now, I think it's unlikely the federal government will contribute on the operating side. On the capital side, they contribute $150 million a year, which runs out in 2 years. We're hoping we can get that back and maybe double it, but again, what are the chances? Hard to know. So your question is a good one, but there's no answer to it. What is the strategy? It's to pursue all of those things. But as I told everyone at the board, and I tell everybody here, on July 1st of 2019, is that it? 2018, July 1st of 2018, not this July 1st, but next July 1st, if nothing changes, we don't have enough cash to run Metro. Okay, we run out of money. So then we have 2 options. We don't run the trains on July 1st, which is not really an option, or we take money out of the capital budget, the money we're using to buy the new train cars right now, and we use it to pay people to run the system. And if you think we're in a death spiral now, that's the end of the game, because we would break contracts, not buy the new 7,000 cars, and use that to run the system, and that just buys us time. So it goes back to the mayor's comment, and it was an excellent one on what the secretary did. How do you get the attention of people who otherwise won't pay attention? We had a woman die on the Metro trains. Didn't seem to get anybody's attention. We stopped the trains for a whole day, didn't run them. Didn't seem to get anybody's attention. So what is it that's going to get everyone's attention of how important this is for the region? And that's the big question. But we're going to keep, Councilman, we're going to keep on it. Keep hammering on it every time I get. That's why today's presentation, you have a lot of press in the room. Hopefully somebody will cover this today, of the dire circumstances that Metro faces and why Maryland and Virginia are going to have to step up to the plate as well as the federal government.
And if I could just add one last thing, that there is a discussion about governance changes and how you change the compact. Right now, Maryland and Virginia, they are in a contract. They have a contract with us, a compact that are between the jurisdictions. So that's why they pay. From our congressional delegation, one from Maryland and one from Virginia, they're throwing around ideas about how to make the governance more robust. Now, many people will argue if that's the way to go or not, but that's up for discussion. But I think also the commitment of the federal government, which should and must go hand in hand with that discussion. So I think those are some other things that are kind of leading towards the end game. What does the authority or the funding jurisdictions need to do to secure more federal support?
Councilmember, I'm going to be the over-optimistic one here. I would say if you go back 6 months ago, in terms of your question about the end game, there was sort of by many jurisdictions, not the stages of grief, if you want to call it that. You know, we're in the bargaining or we're past anger, I think, and we're seeing the whole point. People are now recognizing there is really a you can solve 18 and get the 290 balanced, but 19 has a structural imbalance also. So we're all going to have to come to the table again and put up way more than we're getting in our growth, even the district's growth. And then you look at the capital that you know they need to do. You can look at the car and know it needs to have the transmission replaced, and you can't deny that. It doesn't run right. So I think what I am seeing from the jurisdictions which are starting to impact the states is the recognition that there is a gap. And so the problem has now been recognized. Is now what is the solution? And the solution is we all either take our growth and give most of it and more than we have to Metro, or we find another way to fund it, or the federal government steps in. So there is at least the end game is, there's a recognition of what the cost is to get to the end game and what the solution is. I think if you were to ask Paul Whitfield, I had some discussion with him, he'd say he knows the end of the story, it's just how do you get there? He knows what you have to do, but it's going to require all of us together to do it. So the problem is now recognized. That's a huge step from 9 months ago, in my opinion.
Okay. Thank you, Madam Mayor.
Thank
We'll
you.
see you all next month.
Thank you.
I